Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Neisseria, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 179 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, PBS, a 34-year-old female patient who was recently diagnosed with HIV infection and presents to the HIV Comprehensive Care Clinic today to discuss HAART. Currently, PBS remains asymptomatic. Her pertinent labs include a CD4 cell count of 678 cells per millimeter cubed. Her HIV RNA level is 55,000 copies per milliliter. Hepatitis B and C test results are negative. Her renal and liver function within normal limits. The HLA-B*5701 testing is negative, and HIV resistance testing is negative. So my question to you is, when would you recommend starting ART in this patient? Would it be A. today, if possible, or B. not until her HIV RNA is greater than 100,000 copies per milliliter, or C. not until her CD4 cell count falls to below 500 cells per millimeter cubed, or would it be D. not until she develops symptoms of HIV infection? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Today, if possible. Patients without symptoms of HIV infection should be started on ART to reduce their risk of both AIDS and non-AIDS defining conditions, as well as the risk of transmitting HIV infection to others. CD4 cell count should no longer influence decisions about when to initiate HAART. HIV RNA levels should not influence decisions about when to initiate HAART. Delaying therapy can increase the risk for both AIDS and non-AIDS defining conditions, as well as the risk of transmitting HIV infection to others. In the START study, patients living with HIV infection were randomly assigned to either initiate ART early at CD4 cell counts above 500 cells per cubic millimeter, or delay ART until CD4 cell counts fell below 350 cells per millimeter cubed. Compared with delayed ART initiation, patients in the early initiation arm had significantly lower rates of both AIDS and non-AIDS defining conditions, including deaths from all causes. As a result of this study and others showing a significant reduction in HIV transmission when HIV viral loads are undetectable in infected partners receiving treatment, the current DHHS treatment guidelines recommend initiating ART in all patients with HIV infection regardless of symptoms, CD4 cell count, and HIV RNA levels. Please advance to the next question. And the next question reads, APR, a 48-year-old male patient with HIV infection that is well controlled on Elvitegravir, Cobicistat, tenofovir alafenamide, and emtricitabine was admitted to the hospital and diagnosed with deep vein thrombosis, DVT, after a very long transatlantic flight. On admission, his HAART was withheld by the HIV consultant, and his DVT was initially managed with enoxaparin 90 mg subcutaneously twice daily. APR is now scheduled for hospital discharge and will resume his HAART. The HIV consultant plans to transition him to apixaban 5 mg orally twice daily to complete his DVT treatment at home. So my question to you is, which of the following recommendations would be the most appropriate for managing APR's medications during his transition of care based on the U.S. Department of Health and Human Services, abbreviated as DHHS HIV treatment guidelines? Would it be A. Reduce the apixaban dose to 2.5 mg orally twice daily, or B. Change the apixaban to warfarin, or C. Change the apixaban to dabigatran, or would it be D. Change the ART to darunavir boosted with ritonavir plus tenofovir alafenamide, emtricitabine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Change the apixaban to warfarin. Changing the antiretroviral therapy to a multiple drug regimen for a patient who has been receiving a single tablet regimen is not ideal. Also, ritonavir is a strong CYP3A4 inhibitor that is contraindicated with apixaban. Dabigatran is a CYP3A4 substrate. Its use with cobicistat, a strong 3A4 inhibitor, is contraindicated. Apixaban and cobicistat should not be used together because of a drug interaction. Apixaban is a P-glycoprotein and CYP3A4 substrate, and cobicistat is a P-glycoprotein and strong CYP3A4 inhibitor. Warfarin could interact with elvitegravir and cobicistat because elvitegravir is a mild CYP2C19 inducer and cobicistat inhibits CYP3A4. The metabolism involves these enzymes. However, co-administration of these drugs is not contraindicated. The INR can be monitored during warfarin therapy. Therefore, changing apixaban to warfarin is the best choice at the transition of care for this patient. Reducing the apixaban dose to 2.5 mg twice daily is an option for managing the interaction between cobicistat and apixaban, but changing apixaban to warfarin and monitoring the INR is preferred, according to the DHHS HIV treatment guidelines. Please proceed to the next question. And the next question reads, NAO, a sexually active 26-year-old non-pregnant woman was treated with benzathine penicillin G 2.4 million units stat IM dose after a diagnosis of primary syphilis 6 months ago. She is now asymptomatic and presents to the Sexually Transmitted Diseases Clinic for a follow-up visit to review the results of recent lab tests. Her lab results 6 months ago were as follows: rapid plasma reagan, abbreviated as RPR1-64, fluorescent treponema antibody absorbed, abbreviated as FTA-ABS reactive, HIV fourth generation test 1 week ago was negative. RPR 3 weeks ago and 1 week ago was 1 to 256. So my question to you is, which of the following would be the most appropriate course of action now based on these findings and current Centers for Disease Control and Prevention, CDC treatment guidelines for sexually transmitted diseases, STDs? Would it be A. Give 3-benzathine penicillin G 2.4 million units IM doses at 1-week intervals, i.e., a total of 7.2 million units, or B. Give benzathine penicillin G 2.4 million units IM as a stat dose, or C. Perform a cerebrospinal fluid evaluation to rule out neurosyphilis, and if the results are negative, give 3-benzathine penicillin G 2.4 million unit IM doses at 1-week intervals, i.e., a total of 7.2 million units, or would it be D. Perform a cerebrospinal fluid evaluation to rule out neurosyphilis, and if the results are negative, give benzathine penicillin G 2.4 million units IM as a one-time dose. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Perform a cerebrospinal fluid evaluation to rule out neurosyphilis, and if the results are negative, give 3-benzathine penicillin G 2.4 million unit IM doses at 1-week intervals, i.e., a total of 7.2 million units. The current 2015 CDC STD treatment guidelines recommend that a persistent fourfold or more increase in RPR for more than 2 weeks should be considered a treatment failure in patients with syphilis. This patient's increase in RPR from 1 to 64 6 months ago to 1 to 256 1 week and 3 weeks ago is a fourfold increase, so her treatment is considered a failure. Evaluation of cerebrospinal fluid for possible neurosyphilis is recommended. If this evaluation is negative, retreatment with 3 2.4 million unit IM doses of benzathine penicillin G at 1-week intervals is recommended. If the results are positive, a regimen for the treatment of neurosyphilis, e.g., crystalline penicillin G 18 to 24 million units per day IV, is appropriate. Please progress to the next question. And the next question reads, MNA, a 24-year-old female patient presents for the first visit to your primary care clinic with no significant past medical history. She has no current complaints. Her pertinent labs include a pregnancy test in clinic which turns out negative. Regarding her sexual history, she has had 4 lifetime sexual partners, is in a monogamous relationship with her healthy husband. She has no history of genital ulcers or symptoms. She asks the venerologist whether she should be screened for genital infections. So my question to you is, which of the following screening tests are most appropriate for MNA basing on current Centers for Disease Control and Prevention (CDC) treatment guidelines for sexually transmitted diseases? Are they A. Annual urine nucleic acid amplification tests, abbreviated as NAATS, for both chlamydia trachomatis and Neisseria gonorrhoeae, or B. Annual syphilis serology, rapid plasma Reagan, abbreviated as RPR, or venereal disease research laboratory, abbreviated as VDRL, or C. Annual vaginal swabs with nucleic acid amplification tests, NAATS, for both chlamydia trachomatis and Neisseria gonorrhoeae and syphilis serology, rapid plasma Reagan, RPR, or venereal disease research laboratory, VDRL, or are they D. Annual vaginal swabs with nucleic acid amplification tests, NAATS, for both chlamydia trachomatis and Neisseria gonorrhoeae? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Annual vaginal swabs with nucleic acid amplification tests (NAATS) for both chlamydia trachomatis and Neisseria gonorrhoeae. This patient is sexually active and under the age of 25, which puts her in a group with a high prevalence of chlamydia and gonorrhea. The CDC recommends annual screening using NAATS for both chlamydia trachomatis and Neisseria gonorrhoeae in sexually active women less than 25 years of age, like this 21-year-old patient. Vaginal swabs are preferred over urine samples for the NAATS. Screening for syphilis using RPR or VDRL is not recommended by CDC unless the patient is pregnant. It is not indicated for this non-pregnant woman. Please advance to the next question. And the next question reads, KWA, a 21-year-old female patient presents to your outpatient clinic after having unprotected sex 10 weeks ago requesting a pregnancy test. The test turns positive, computing basing on her last menstrual period. She is 21 weeks pregnant. KWA consented to screening for sexually transmitted diseases, STDs, at the time of her pregnancy test. 2 days later the clinic notifies her that she has tested positive for syphilis with a reactive fluorescent treponema antibody absorbed, abbreviated as FTAABS test. According to her prior records, she had negative test results 6 months ago, and rapid plasma Reagan (RPR) titer of 1 to 64 from 2 days ago. She has no symptoms of syphilis. She is allergic to penicillin. She had an anaphylactic reaction in childhood when she took penicillin. So my question to you is, which of the following would be the most appropriate management for KWA's syphilis? Would it be A. a penicillin skin test to confirm the allergy, followed by a penicillin desensitization protocol in the hospital, and benzathine penicillin G 7.2 million units divided in 3 2.4 million unit IM doses at 1-week intervals, or B. a penicillin desensitization protocol in the hospital and benzathine penicillin G 2.4 million units IM stat, or C. a penicillin skin test to confirm the allergy, followed by a penicillin desensitization protocol in the hospital, and benzathine penicillin G 2.4 million units IM stat, or would it be D. doxycycline 100 mg orally twice daily for 4 weeks? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. a penicillin skin test to confirm the allergy, followed by a penicillin desensitization protocol in the hospital, and benzathine penicillin G 2.4 million units IM stat. Doxycycline cannot be safely recommended for pregnant patients with syphilis. A penicillin skin test to confirm the allergy, followed by a penicillin desensitization protocol in the hospital, and benzathine penicillin G 2.4 million units IM as a one-time dose is the current guideline-recommended treatment method for management of syphilis, in this case early latent syphilis, in a pregnant patient with an allergy to penicillin. Patients with a history of anaphylactic reaction do not necessarily continue to have this allergy for their whole life, which is why verifying the allergy through penicillin skin testing, which will detect IgE-mediated reactions, is suggested. Option B would be correct if you assume the allergy is a true allergy without confirmation. The treatment in A would be for late latent syphilis, but this patient has early latent syphilis. Please proceed to the next question. And the next question reads, JTA, a 34-year-old male patient presents to your accident and emergency department with a chief complaint of rash, headaches, new onset hearing loss. He has a past medical history significant for chronic HIV infection. His pertinent labs include a serum venereal disease research laboratory, VDRL titer of 1 to 64. A lumbar puncture is performed, and the cerebrospinal fluid, CSF, shows 32 white blood cells per millimeter cubed and a cerebrospinal VDRL titer of 1 to 32. He has no known drug or food allergies. The venerologist orders penicillin G 24 million units once daily administered as continuous IV infusion for treatment of neurosyphilis. The nurse calls the infectious diseases pharmacist 5 hours after the start of the infusion and notes that the patient has developed a worsening of the rash and a new onset of fever. So my question to you is, which of the following would be the most appropriate course of action to recommend to the venerologist treating JTA? Would it be A. Recommend acetaminophen to manage the fever and close monitoring for hypotension because the rash and fever probably a Jarisch-Herxheimer reaction, which should resolve within 24 hours, or B. Recommend stopping the infusion because the rash and fever probably are an acute allergic reaction to penicillin, and substitution of ceftriaxone 2 grams IV daily would be appropriate, or C. Recommend stopping the infusion because the rash and fever probably are an acute allergic reaction to penicillin, and desensitization will be needed, or would it be D. Recommend slowing the infusion and close monitoring for hypotension because the rash and fever probably are an infusion-related reaction that will improve within 24 hours. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Recommend acetaminophen to manage the fever and close monitoring for hypotension because the rash and fever probably a Jarisch-Herxheimer reaction, which should resolve within 24 hours. Using acetaminophen to manage the fever and close monitoring for hypotension are the most appropriate recommendations because the rash and fever probably reflect Jarisch-Herxheimer reaction, not an allergic reaction. The reaction should resolve within 24 hours, although close monitoring is needed due to the risk for hypotension. The Jarisch-Herxheimer reaction occurs in response to the treatment of the syphilis. It is not an infusion-related reaction. Please progress to the next question. And the next question reads, PLK, a 19-year-old male patient who has sex with men, abbreviated as MSM, visits your sexually transmitted diseases clinic to get an HIV test, undergo STD screening, and receive counseling about any appropriate preventive health measures. In the past 6 months, he has had 4 partners and they practice insertive and receptive anal and oral sex. He has no significant past medical history and he last received a vaccine at the age of 8 years. With regard to his sexual history, he uses condoms during sex most of the time. His overall health is good, and he currently has no genitourinary or oropharyngeal symptoms of infection. So my question to you is, which of the following screenings and immunizations should you recommend in your counseling for PLK basing on recommendations from the CDC? Should you recommend A. Screening for chlamydia and gonorrhoeae at the urethral site at least every 6 months and begin the human papillomavirus (HPV) vaccination series using the 9-valent vaccine today with follow-up doses in 2 months and 6 months, or B. Screening for chlamydia and gonorrhea at urethral and anal sites at least every 6 months and begin the human papillomavirus (HPV) vaccination series using the 9-valent vaccine today with follow-up doses in 2 months and 6 months, or c. Screening for chlamydia and gonorrhea at urethral, oropharyngeal, and anal sites at least every 6 months without the human papillomavirus (HPV) vaccination series. Or should you recommend d. Screening for chlamydia and gonorrhea at urethral, oropharyngeal, and anal sites at least every 6 months and begin the human papillomavirus (HPV) vaccination series using the 9-valent vaccine today with follow-up doses in 2 months and 6 months? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Screening for chlamydia and gonorrhea at urethral and anal sites at least every 6 months and begin the human papillomavirus (HPV) vaccination series using the 9-valent vaccine today with follow-up doses in 2 months and 6 months. Currently, the CDC recommends screening men who have sex with other men, otherwise known as MSMs, for chlamydia and gonorrhea at urethral and anal sites at least every 6 months. Screening for oropharyngeal infection is not currently a standard recommendation for asymptomatic patients. This patient meets the CDC criteria for initiation of the 3-dose HPV vaccine series using the 9-valent vaccine, with the second dose given 1 to 2 months after the first dose and the third dose 6 months after the first dose. Failure to screen at the anal site is a common mistake in the MSM population. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Neisseria, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 180.